Macaulay. Wonderful. Good afternoon. Well, good morning, everybody. So, just a show of hands, just so I know who I'm talking to. Bariatric surgeons, show of hands. Okay. Doctors, medics, allied health professionals. Ooh, okay, we've got a chance, guys. I've got a chance. Okay, good morning. Okay, so I'm going to, over the next sort of 10 minutes, try to talk, as Alex says, in an intellectual forum, to try and talk about intervention. So these are my declarations. So we're going to go on a little trip. We're going to go on a little trip that you might say, well, the House believes that lifestyle interventions are the best treatment option for obesity. Why would you think that? We've had a lovely debate with Ahmed before that tried to convince you that medication was the way to go. And clearly, unfortunately, Ahmed, you spectacularly didn't convince them. I'm going to try and convince them on something even less likely now. And I hope by the end that you are going to realise that there's only one answer truly for severe obesity, and that is lifestyle intervention, and to vote for me. So the aim of the session, we're going to be talking about lifestyle interventions, the proof is in the pudding, why drugs and surgery aren't what they say they are, lifestyle for the win. I'm going to do a mic drop virtually and you're going to applaud, just so we're getting up with what's going to happen. So, just a quick question. What is the main mechanism of weight loss in surgery and pharmacotherapy? How does it work? Calorie deficit. Fantastic. So that's how it works. Yeah? But what do you need for calorie deficit? You need to reduce down your intake of food. How does it do that? So ultimately, diet is an absolutely core element of everything that these two interventions do. And so, what are lifestyle interventions? They're comprehensive lifestyle modifications that are the first part of lifestyle interventions. They involve diet, physical activity, and behaviour change. And I'm sure, ladies and gentlemen, you all agree that behaviour change and diet are absolutely key to any type of success with bariatric surgery or medications. But what we do know is that adding them together, diet and physical activity, we produce better weight loss. And this is data from the Look Ahead trial and also the diabetes prevention program. Now, hands up. I'm going to admit right now that for absolute weight loss, bariatric surgery and pharmacotherapy are the winners. But without lifestyle interventions and dietitians, psychologists, physiotherapists, the thing is that you need us in order to make these successful. And whenever you have a complex patient who has weight regain, and we'll talk about that in a moment, who gets involved and what is the focus? The focus is on lifestyle intervention. So, this is very much the proof is in the pudding data from NICE identifying that lifestyle interventions are involved in every single stage across the board, including those with severe and complex obesity. And we have the obviously increasing cut-offs for both pharmacotherapy and bariatric surgery. But it is everywhere. So why lifestyle interventions? They're scalable. So we talked about today about access to drugs, access to bariatric surgery. We can do it tomorrow, and we can do it with a large number of individuals. The cost is low. The cost is around £800 for that 12 months. It's easier to implement. I can teach someone around dietary change incredibly easy. It's incredibly difficult to find someone, A, to prescribe the medications. We need to get people to be able to prescribe them. But you've trained many years, ladies and gentlemen, to become bariatric surgeons. We can't just magically get you there, but we can look to train other people. It's accessible to large numbers of individuals, but also it's effective. So this is data from France looking at lifestyle interventions, and what we can see is that at around 6 months we can generate significant amounts of weight loss. This is data from low energy diets, achieving around 18 kilos weight loss in certain individuals. But I do agree that typical lifestyle interventions do not necessarily produce as much weight loss, but we are seeing that with significant, with certain groups. It's clinically effective. This is data from very low energy diets. This is data from Helen Peretti looking, and obviously when we look at comparing very low energy diets with control, we can see that actually the mean difference is around 4 kilos and significant, but the amount of weight loss varies from 7 kilos up to 14 kilos, so almost equaling in some respects some of those pharmacotherapy medications that might not be touching on bariatric surgery in certain individuals. Type 2 diabetes remission, I'm not going to go over this in too much detail. This is obviously the direct study identifying that those individuals using a low energy formula-based diet at 1 year achieved around 50% remission and at 2 years around a third. Obviously this has gone down at 5-year data and we're seeing about 10% in remission. But I would say even with bariatric surgery, we see remission reducing over time and a large number going back, but also remission is not possible at the present time, according to the definition, with pharmacotherapy at all. So we can only achieve it with drug, with diet and physical activity. Weight maintenance as well, and this is data from the look-ahead study identifying that individuals that that were more likely to achieve 10% weight loss at 4 years, ate less and did more physical activity. And this is data from the National Weight Control Registry, which is individuals that achieved 10% weight loss and maintained it for 2 years. And they identified that it showed that 80% of those had breakfast. So really identifying that dietary change for weight maintenance is incredibly important. And also there's less side effects. We know this from the data related. I'm not going to go over those today. But if you want it, the only way you can get drugs is if you are either Elon Musk, you're a Kardashian, or an A-level star. So pharmacotherapy, there's currently still remains a relatively global shortage. Stocks when are we going to get stocks back, Alex? I don't know, but the stocks of how we actually get hold of them, who knows? This is actually data from the drug company as well, saying that actually that diet and physical activity are essential for the drug. They are an adjunct, and Alex is laughing slightly there. But also semaglutide at the present time is only available in tier 3 services. Obviously with the change of tirzepatide and the funding variation, this might move into primary care, but at the present time it's only available in specialist services. And obviously, unfortunately, we're now seeing occurrences of people unfortunately passing away. This is recent data here. People are attempting to get drugs from everywhere. And unfortunately, this is resulting in a large amount of drugs that actually might not be the medication they're predicted to be. So let's go on to surgery. So less than 1%. I think I should have just had Ahmed come up and argue the point. You did it very well and almost took all my points, which was great. But I'm just going to reinforce them. Less than 1% of eligible people get access to bariatric surgery. This is data from the MBSR, showing quite clearly the number of operations has significantly reduced down since a high at 2015. Access is limited. Needs to have a tier 3 service often before, and only 50% as identified before have access. And there's a huge waiting list, and I've spoken to multiple people around this access, is that people aren't necessarily referring to bariatric surgery, for example, people that are wanting kidney transplants because of that weight. So they're looking to do other reasons. It's in the money. We don't know how much it's going to cost, Alex, unfortunately, at the present time. So is pharmacotherapy the way to go? With 67 million people living in the UK, that's around 20-odd million people. From the estimations from the tirzepatide funding variation, they estimated that 2.8 million people would be eligible. This is going to overwhelm primary care. If I'm going to put it from the fact of dietitians, by year 2, if they do not do a funding variation, every single appointment in primary care dietetics will be taken up simply to manage this drug. So there needs to be variation. It's going to cost a lot, 2.9 billion is estimated at 2 years. And this is just showing the number of appointments that need to be done, and what we are concerned about particularly is actually actually people getting hold of people, but also jobs as well, and actually getting people to be able to be seen by dietitians, because we don't have enough. Funding variation has increased, and this is identifying that actually now the predicted funding variation will be only for 42,000 people over 18 months, with a BMI of 40 and 3 qualifying comorbidities. So what that's saying is, if you do not have cardiovascular disease, if you do not have hypertension, obstructive sleep apnea, or hyperlipidemia, you don't get the drug. So if you have anything else, severe mental illness, or, for example, kidney disease, or anything else, and you don't have these 3 coordinating, you don't get access. Bariatric surgery, it costs around 5 to 12,000. There can be a lot of complications. And Dimitri, when it goes wrong, it goes wrong. And there's a lot of costs potentially on ITU, reoperations, etc. But I can admit it is very, very cost effective. And I know that you'll be talking about the nice cost evaluation later on. But once you stop it, you regain it. As we saw from Ahmed, if you stop the drug medication, this is data from tirzepatide, there's an increase in weight, but also we see an increase in weight, and I'm really happy that Barbara and Gowan's here, because this was your study, wasn't it? Showing very clearly that drugs, once you stop them, you regain weight. In terms of maladaptive eating behaviours after surgery, this is very clear that they will negate all positive effects if people return to grazing, eating energy-dense foods as well. And this is data showing, and this is data from Ahmed as well, that identified that over time, so this is weight regain here, so this is 10 kilos, this is 25% maximum from their NADA. By the time 5 years has happened, nearly 2/3 have gained 10 kilos, and nearly 50% have actually gained over 25% of their NADA weight. And this also identifies the variation that around 50% regain around 20% of their weight loss, and over time, even people regain a small amount up to 100%. We know that these medications, and this is some data, and actually Jess Mock is here, who actually did this study in our group, that looked at taking people that had suboptimal weight loss after bariatric surgery and giving them liraglutide. And what we can see is by giving them medication, that actually helps them to lose weight. And this is showing the variation of this. But I would like to just return to what Alex Miras says about medications and about weight regain. This is his direct quotes. The trajectory of weight regain is typically faster at the time. According to Miras, people put most of the weight back on after 3 to 6 months of not stopping it. But also, he says that weight regain is usually accompanied by more fat and less muscle. So really identifying that actually there's concerns about stopping this medication. But finally, what does Alex, Miras, and Dimitri say about lifestyle change? Now, Alex is very happy about his comments about a lifestyle change. And he says, this is medications about talking about lifestyle and exercise. Yes, because weight loss will result in better combined with the drug with a healthier lifestyle, identifying that actually there's a need for both diet and physical activity. Let's see what Dimitri says. Dimitri is less happy about talking about lifestyle and medication. But again, this is what we say, that weight loss requires food intake and physical activity. It requires a reduction of food intake and increased activity. So really identifying that even these medications do require those types of, do require physical activity. So in summary, lifestyle modifications are primarily in all these options. They're scalable, they're effective, they don't cost as much, they're accessible to all today, ladies and gentlemen. You can do it today. There's no need for lengthy workups, and there can only be one winner if you're going to be looking at people with severe obesity, is lifestyle interventions. Thank you for listening. I'm going to do a virtual mic drop, and you may applaud.
I also didn't think this was a debate.
I thought it was a debate.
But it was good. It was because you worked hard for this.
Yes.
It was very Very good. Right. What do I press? That's the image. Okay, great. So we've got quotes and issues that we are facing today in our practice, but I think that we should not be solving today's problems. We should be solving tomorrow's problems. One way of solving them is through pharmacotherapy. Now, what I will be doing is I will actually be presenting some evidence of how to treat severe and complex obesity. Now, we call this severe and complex obesity. I'm not entirely sure what that means. It's a nice term. What's the difference between severe and complex? Is it severe based on body mass index? I would suggest that we start just stick with severe in terms of complexity, in terms of complications, rather than just the body mass index and treat it as that. So we're talking about the treatment of severe obesity because of obesity-related complications. And these are my disclosures. So I will not be talking about weight. I'll be talking about what drugs can do to improve specific obesity-related complications that make people sick, independently of their body mass index. And these are some trials that you will have seen already. Maybe some of the ones I will be presenting might be a little bit more fresh. So this is now all data from liraglutide at the 3 milligram dose Saxenda, which was given to people with obstructive sleep apnea. And you will see a nice reduction in the apnea-hypopnea index, moving people from pretty severe sleep apnea down by about, as you will see here, about 15 minutes or so, maybe a little bit more, yes. Which is not bad. And remember that the weight loss in this study was not that much. But it seems, and I think that the sleep apnea improvements are probably almost entirely weight loss dependent. And I think this is also reflected here in this newer study on tirzepatide 15 milligrams that was used again in people with sleep apnea, in people with and without using the CPAP ventilation at night. Now you're seeing even more impressive reductions. The change from baseline in the apnea-hypopnea index of approximately 30. So you can take someone who has got severe sleep apnea, like the liraglutide trials, of 50 events per hour, and drop them down to about 30. So you're really, again, changing the disease process here in the same way that we're changing the disease process for diabetes. So obesity can be a disease-modifying intervention, and this is what we're seeing here specifically when used with pharmacotherapy. And the good thing about pharmacotherapy, I suppose, is that it is sustainable. So what I mean by that is if people continue to take the medication, they are likely to sustain most of the effects. It is true that we don't have longer data than 4 years for pharmacotherapy, but we will obtain it. And you need to remember that pharmacotherapy only started becoming relevant really since 2015, if not 2017. So the fact that we already have got those data is pretty good. Now we're moving into more complex stuff, and we're talking about cardiovascular disease and atherosclerosis. You'll probably be familiar with this seminal trial of using semaglutide 2.4 milligrams in people with obesity and established atherosclerotic disease, not diabetes, with a 20% reduction at 4 years in the incidence of adverse cardiac events. The weight loss was modest, I would say, only 10% in this trial. People who lost less than 5 and people who lost more than 15% of their body weight had exactly the same improvements in cardiac function, suggesting that things are now becoming more complex, not only in terms of obesity, but in terms of our treatments. And they're suggesting that these hormones are actually hormones that can be used to treat cardiovascular disease directly, independently of weight loss, which just happens to be a positive side effect. And we will continue to see more and more studies on the effects of these medications on heart disease. This is nice data for semaglutide, again 2.4 milligrams, in people with heart failure with preserved ejection fraction, which is notoriously pretty difficult to treat. And what you are seeing here, this is the Kansas questionnaire for heart failure. Very substantial and clinically meaningful improvement with semaglutide. And again, the weight loss is there, the mean weight loss is 30%. It's okay, but not likely to explain this very impressive outcome. It is true, we need longer data, and we will get it, but this is all looking very positive. And we're actually now going to see tirzepatide causing something similar. I don't think this has been published, but it will be published soon, with actual measurements of cardiac function. So you take sick people and you make them not completely healthy, but much healthier, and much more likely to be functional, go back to work and do the things that they like. Survodutide has not been approved yet. It's undergoing phase 3 studies now. And what you will see in this phase 2 study for people with metabolic associated steatohepatitis is that here we start, and so I should say, survodutide is a combination of glucagon and GLP-1 made by Boehringer Ingelheim, so it's going to be the first in its class. And here, in terms of liver biopsies, you will see percentage of participants with an improvement in the steatohepatitis score without worsening of fibrosis, and you see the percentage of people at each of the doses of survodutide. And we're looking at about an average of 50% of people achieving improvements with more than one stage decrease in fibrosis in about 30% of people. What you will notice again is that there is no clear dose-dependent effect here. So we don't see a clear dose-dependent effect in terms of weight loss and improvements in these outcomes. And the probable reason for that is that weight loss is one of the mechanisms through which survodutide works. But glucagon, independently of the weight loss, is known to clean the liver from fat. So again, emphasizing that weight loss is one of the ways that we can improve severe and complex obesity, and there can be direct effects of these medications on severe obesity independently of weight loss. Exenatide, which is now all news, available around 2006 or so, and modest weight loss again, about 5 to 10% maximum, really. A study that may not be so familiar to some of us, which treated women with idiopathic intracranial hypertension, which can be a very complex form of obesity that can drive some people blind, tends to be women that have this condition more than men. It causes a lot of headaches and disability in daily life, and you'll see that even with exenatide in its modest effects way, you're seeing the difference in terms of the intracranial pressures. You're seeing the reduction in the number of days during the month that people are suffering with headaches, about 7 days less per month. That's pretty good. And also an improvement in visual acuity. This is the reverse, so it goes down, but this represents an improvement in liver acuity. So I'll finish off by saying that I thought some years ago that this pyramid of treating people with severe obesity was a little bit old-fashioned, and that, again, as you know, I'm a big fan of surgery, so I would say, if someone has got severe diabetes or severe intracranial hypertension, they should go straight for surgery. I have changed my mind over the years, and I will explain why. Of course, if there is a real urgency, if you cannot wait to try different bits and pieces, of course you should go for surgery, because it is the most likely in terms of probabilities to give you what you want for the severe case that you have in front of you. But the reason why I would actually, on this occasion, agree with Aidan that you should be trying first the lifestyle changes, then the medications, and then bariatric surgery followed by combinations, is because you don't know, and you really don't know, how well the patient will respond. Which means that if the patient sees Adrian in his dietetic clinic and the patient happens to be a responder to this lifestyle intervention and loses 20% of their body weight, that can be enough to improve their obesity-related complications. If it's not enough, you shouldn't, of course, be revisiting this round and round expecting a different answer, because that's the definition of stupidity. So what you would do then is you could try to go into pharmacotherapy, because again, you don't know whether the patient will be a super responder. So people will lose 30% of their body weight with tirzepatide, and that patient might be sitting in front of you, and therefore you're saving them from a potential operation, not a saving in the past term. You're not exposing them to the potential risks. But it is true that if people do not respond to this pyramidal approach, then obviously we are going to be needing surgery as the treatment that's much more likely to give them what we want. And they may also need additional pharmacotherapy after their operations if their disease has not improved to the way that we would like it to. Thanks for listening.
To talk about surgery.
I also took the approach of a forum, not a debate, in a much more Roman way where we'll do syntheses. But more importantly, I am the one person standing between you and the coffee break. So I'll keep it brief. So I think both my colleagues have done a great job summarising some of the information there. I've changed my title, so I will not debate and convince you that the best treatment is bariatric surgery. It is not actually. It is the treatment that works for the individual patient in front of us, and we need to do more multimodal treatment. And I will share some of my thoughts on that. These are my topics of interest, and it reflects the fact that I work with a variety of organisations to treat this very complex disease, and that includes surgery and pharmacotherapy and endoscopy. And I think you all know that I am a full-time surgeon, but just like Vinod, I do prescribe the medications and I do endoscopy, and by definition I provide lifestyle advice. And in fact, the most successful one that we know is the very low energy diet as a liver shrinking diet, and I think that most of us who do bariatric surgery use that in a routine fashion. Alex had these very nice slides about heterogeneity. I'm going to show you another one. So this is the largest published series of wide gastric bypass in the UK. This is from Taunton, and quite a lot of people in the audience, including Sanjay and Agrawal and Alvin Cotter and many others, we worked in Taunton at the time, and this is operation we did, and the follow-up has continued over 20 years. And you can see that high BMI 50, and remember that this is the standard population we see in most NHS practices, and you see that at 10 years it goes down to 38, people still have the disease, but you see the variation. And what is key is that people who do not respond to surgery, they're not interested in the debate about lifestyle versus pharmacotherapy versus surgery. They want good treatment, they want a better outcome, and that's what we should be focusing on. I'll share some thoughts on the pharmacotherapy data, and this is a systematic review we did on 30 years of pharmacotherapy trials. These are registration trials for approval. This is what the regulators are doing, and that includes most of the studies that you saw presented today. So you'll see that the BMI is constant in the last 30 years around 35. It's very low compared to the population we see in the UK in most of our weight management services, in most of our obesity specialist services. And that changes very little when you include people with or without type 2 diabetes. So we need to be careful about the population we're studying. And it is predominantly female population. I would argue that this is the same for bariatric surgery. But what is really important is to look at ethnicity. The vast majority of people included in those clinical trials that Ahmed showed very nicely earlier on, Alex did, and we go back and back time and time again, they're predominantly white. And we all know what the impacts of ethnicities on BMI, and our population reflected in London, in this international meeting, not actually reflected in the studies that we do. And there's a regulatory issue around that. We all have to do better, to do more valid science, but there's also a regulation issue. Our regulatory authorities also need to understand that. So important to recognise the limitation of the studies. Adrian mentioned diabetes remission, and this is Francesco Rubino's study, the Giulio Migrone study from 10 years ago. The randomized controlled trial using biliary pancreatic diversion. You didn't hear anything about this operation in this meeting anymore. We don't do it as often, of course, but you'll see that it was the most effective treatment option for type 2 diabetes. It has an almost mechanical effect on diabetes remission. At 5 years, with strict criteria, not a single person went to remission for the diabetes. But they did demonstrate a reduction in cardiovascular risk, and they're saving lives by doing this operation. So it's important to recognise the limitations, even for surgery, and see how we can actually combine modalities. And the first time the term multimodal treatment for obesity and type 2 diabetes was used at the time in an editorial I called with Carl LaRue. And it's important we go back, and you heard this from earlier on from Professor Philip Menon about the need to use the parallels of cancer. We do not have fora or debates, for that matter, in oncological meetings about surgery versus chemotherapy or radiotherapy versus surgery. And I think we need to stop doing that in the field of obesity. We need to combine modalities and understand which are the patients that respond, and Alex said that very well early on, understand what the prediction models are. Very poor at the moment, worse than a coin really, so we can provide better care. I'm going to try to be philosophical. I'm not allowed to use ancient Greek philosophers due to my accent and my nationality. So this is Andrew's. Everything has already been said, but we keep forgetting, so we have to keep reminding ourselves. And our colleagues in oncology have done this for decades, and that's why our outcomes are getting so much better. We need to be clear about what we're trying to do. It's different trying to do adjuvant therapy or neoadjuvant therapy or rescue pharmacotherapy or even palliative treatment, which we do for cancer, and I would argue we need to do for obesity. There are a lot of our patients who do not have any available option to them. And we need to be clear about the indication. And this is what I said about adjuvant, neoadjuvant. Do we wait for the outcome of surgery to be reduced? And I would argue when we do breast cancer surgery, we don't wait for the recurrence to start hormone therapy. It starts immediately after surgery. We need to do studies to demonstrate safety, efficacy of combining those modalities, and we need to do that urgently. And then we need to give the treatments as people's functional obesity-associated diseases return due to recurrent weight gain. And that will happen after lifestyle, that will happen after pharmacotherapy, and of course will happen after surgery. We need to use high quality in the modalities we use in studies. We cannot have surgery of yesterday with the medications of last week. So we need to be using gold standard modalities for surgery, for pharmacotherapy, for lifestyle. And we need to do the studies. We need to stop modelling the results and actually measuring what the outcomes are. And we also need to understand, and I think that's what Aidan showed that very well, and you, Alex, we don't have a treatment target. So we don't know what are we trying to achieve in the obesity clinic for the patient in front of us. Is it BMI, percentage weight loss? We don't do that for any other condition. We don't reduce blood pressure as a percentage where we started. We have a target, A1C, 6.5. There's plenty, I can see at least a number of diabetologists here. Where's the evidence for that? That comes from type 1, if I'm correct. And we use it in type 2 diabetes all the time. A poor target is worse, a poor target is much better than no target, which is what we have in obesity right now. So we cannot escalate treatment. And you saw the pyramid that Alex showed earlier on. It's not clear to how to navigate this if we don't know what the target is. And we need to start looking at those, and they're likely to be a combination of factors that will determine the targets. Having shown you how to do this as oncology specialists, I'll show you how to do this as obesity experts, which is look at type 2 diabetes, because that's what we always do. It's a disease that it's more recognized, it's still considered a condition that has to be treated as opposed to obesity, but we're still fighting battles and we're still trying to operate on less than 1% of the population who benefit from that. And that's what they did. And this is the reason that most of our patients who have diabetes in any of our practices outside obesity, if you like, they get all the tablets and all the treatments early on. They get the statins and they get the ACE inhibitors and they get the dual platelet agents very early on. And when you do that, and they showed that's some time ago, this is a standard 2 study from Denmark, you'll see that they were able to have an improvement in survival. And that's what we need to do for people with obesity. So my take-home messages are that we need to treat obesity as a disease. It's just like any other disease, and therefore we need to address this stigma. So most of our patients who do not get a good response, we tell them to go back and try harder. We do not do this with hypertension. We do not do this. It's worse than being stupid, Alex. It's actually harmful. Because being stupid could be naive, but it's harmful. We tell people that have had lifestyle intervention in the best hands. And by the way, Adrian, I need to change the website in our hospital. But thank you for showing a picture when I was a lot younger. We need to address that. We need to stop telling people to go back to lifestyle and try it again for the 15th time, because this really harms people. And we need to stop what happens at the moment, which is nothing. Clinical inertia, we do nothing. The vast majority of our patients get none of those treatments we discussed today. The vast majority of people get no treatment. We need to find the target and aim to meet it. And we need to do this with multiple models of treatment. Thank you very much for your attention.
So I know this wasn't a debate, but it's just turned into one. A very entertaining one nonetheless. A couple of comments then, maybe a poll at the end as to what you think optimal treatment is, just from the audience.
Science.
Studied science. It's true.
I think the debate is on severe obesity, isn't it? Yeah. Best treatment for severe obesity. And great talks all three of you guys. And Aidan, you have been lively.
I am.
You are should be a stage actor in Shakespeare's play. Okay. Now, because it's severe obesity, I mean, I just being a surgeon, I like to look at a surgical point of view. Where else can you see a diabetic patient stop diabetic medication apart from bariatric surgery? The next day, we stop with tablets, by and large. And that is the only reason why severe obesity or people with this sort of condition, like other conditions where you have a sustained reduction or improvement in the comorbidity and sustained long-lasting betterment. So, although it can be done, but I do agree, we need to combine that with lifestyle modification and some medications for weight gain. That's my personal view. But would you agree with that?
Can I just make a comment on the, thank you, Chandler, for the comment around stopping medications. I think we need to stop saying that bariatric surgery is a treatment option that stops tablets. Because by definition, the next day after surgery, we've started, if not earlier, we've started multivitamin tablets. So I think we need to stop saying this, that this is what we do. Hear me out, please, Andrew. So I think we need to say that a lot of our patients may be able to stop some of the medications for diabetes. I don't necessarily think that this is the right thing to do. I don't think there's anything wrong with giving metformin. What we do is that we have long-term outcomes with good results. But I think the stopping medications is something we need to move away from.
No, it's not about stopping medications, it's about reducing or getting away from medications which you have been using for 5-10 years. For example, you reduce insulin or stop insulin, go on tablets. So, whereas diabetes, with bariatric surgery, you will do that with the support of the bariatric surgical motion for severe obesity. We're not talking about mild obesity, the topic was severe obesity, that's where I come from. But I do agree, we've got to get away from resolution or cure. I agree with that. Thank you.
I think it's coffee time. And just before we do that, should we do a quick poll? So, who agrees with Dr. Brown that lifestyle intervention is the answer to severe obesity?
Come on, there's got to be one person. There we go. Come on, Peter. Come on, people.
So the coffee is an Adrian, actually.
Yeah, exactly. I'll be taking you for dinner. It's fine. There we go. Come on. Yeah, Barbara.
Anyone for Alex's view of pharmacotherapy? Any support for that? I'm voting for all three. Finally, bariatric surgery.
Exactly. May I say, every time I do this, I'm either in front of diabetologists or surgeons, and I just come up and try to talk about diet, and every time I lose.
I can't just say one thing on that. One sentence. we have done this, the three of us, in other fora,
Yeah.
and surgery usually loses. It's
It
important
does,
to recognise
yeah.
that it's very uncommon for surgery to win.
Yeah.
He just says it doesn't matter, it's the audience.
Yeah, exactly. That's really right.
The important thing is they're all friends and it's coffee time.
Exactly. Thank you.